Hello! Welcome to another episode of Ask PA Mimi. Get ready, and let's make health make sense. Today, we will be learning about pericarditis. Pericarditis is an inflammatory condition of the pericardium. The pericardium is the fibrous sac surrounding the heart. Pericarditis may occur as an isolated condition or in association with systemic disease and can be acute, recurrent, or chronic. The causes of pericarditis could be infective or idiopathic, and the infective causes are usually viral. Examples include coccidiovirus, echovirus, influenza, and HIV bacterial infection, like tuberculosis. Idiopathic causes of pericarditis include autoimmune, for example, SLE and rheumatoid arthritis. Post-myocardial infarction, like Dressler syndrome, post-cardiac surgery or trauma. Malignancy, uremia, for example, renal failure. Drugs like hydralazine or isoniazid and radiotherapy. Risk factors include recent viral infection, recent myocardial infarction or cardiac surgery, autoimmune or inflammatory disease, chronic kidney disease, malignancy, immunosuppression. Signs and symptoms include sharp pleuritic chest pain, worse on inspiration or lying flat, relieved by sitting forward. Dyspnea, fever, particularly in infective causes, palpitations, pericardial friction, classical but transient, and tachycardia. Signs of pericardial effusion or tamponade if present include things like hypotension, raised JVP, and muffled heart sounds. First-line investigations include ECG blood tests like full blood count, CRP or ESR, and U and E's, and troponin to assess myocardial involvement, and a chest X-ray. Second-line investigations include transthoracic echocardiography, which assesses for pericardial effusion and cardiac function. Autoimmune screen if clinically indicated. Blood cultures if infection is suspected. Gold standard investigation is a cardiac MRI, which confirms pericardial inflammation and detects myocardial involvement. Or CT chest if MRI is contraindicated, or to assess calcification. Diagnosis is clinical and supported by investigations. Acute pericarditis is diagnosed if two or more of the following are present: typical chest pain, pericardial friction rub, typical ECG changes, new or worsening pericardial effusion, raised inflammatory markers like CRP or imaging evidence of pericardial inflammation. ECG changes include widespread saddle-shaped ST elevation, PR segment depression, normalization of ST segments, T-wave inversion. Changes are typically diffuse or widespread, unlike myocardial infarction, which is usually regional. Management according to NICE guidelines include general measures like admit if higher-risk features present, such as fever more than 38 degrees Celsius, large pericardial effusion, cardiac tamponade, immunosuppression, trauma-raised troponin. First-line pharmacological management include NSAIDs like ibuprofen or aspirin, given with gastroprotection, PPI, and colchicine, used as an adjunct therapy to reduce recurrence and typically continued for 3 months. Second-line management will be only if NSAIDs and colchicine are contraindicated or ineffective. Also treat underlying cause, for example, antibiotics for bacterial pericarditis, dialysis for uremic pericarditis, immunosuppression for autoimmune causes, pericardial drainage for cardiac tamponade, suspected bacterial or malignant effusion. Complications include recurrent pericarditis, pericardial effusion, cardiac constrictive pericarditis, myopericarditis, and chronic pericardial disease. Thank you for listening, and let me know in the comments section what other topics you would like to listen to. Don't forget to subscribe, comment, and like for more videos.